Good afternoon, everyone. It's 12 o'clock, 28 April 2021 on a Wednesday, Singapore time. And I welcome everyone to this APSC Cloud Forum of Cardiovascular Disease series. Today, I'm quite excited to hear from my faculty as well as the panelists on vulnerable plaques in atherosclerotic cardiovascular diseases. Is this really a risk marker or interventional target? My name is Jack. I'm the chairperson for session 1, practicing interventional cardiologist based out of Singapore, the current president for the Asian Pacific Society of Cardiology, as well as the president for the International Society of Cardiovascular Pharmacotherapy. We are very pleased and honored to have our chairman 2 for session 2, Professor Paul Gao from Taiwan. He's a professor of medicine at the National Taiwan University College of Medicine, NTUH. Our first speaker is my good colleague, Dr. Chin Chi Yang, cardiologist at the National Heart Centre, Singapore. He's going to speak to us on vulnerable plaque catheterization by coronary IVUS OCT imaging in acute coronary syndrome. Is this a risk marker or interventional target? This will be followed by Dr. Simonette from the Philippines. She's going to then speak to us on vulnerable plaque catheterization by coronary CT or CMR angiography in stable CAD. Is this again a risk marker or interventional target? Our third speaker for session 1 will be Professor Sazali Kasim from UITM Malaysia, and he's going to talk to us on evidence-based optical medical therapy for vulnerable plaque stabilization and regression in ASCVD, from cholesterol lowering to anti-inflammatory therapy. This will be followed by session 2, chaired by Professor Gao. Our first speaker then will be Dr. Hiromasa Otake from Japan. He's going to then transit to vulnerable plaque catheterization by vascular imaging in peripheral arterial disease, a risk marker or interventional target. Dr. Mao Xinlin from Taiwan is then going to talk about plaque catheterization in carotid and cerebral arterial disease. Again, is this a risk marker or interventional target? Our last but not least speaker is Dr. Yadev Bhatt, cardiac surgeon actually, the president of the Cardiac Society of Nepal. And he's going to speak to us on evidence-based antithrombotic therapy for vulnerable plaques in ASCVD from DEB to NOAC. A disclaimer, the content of this webinar is currently copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. The current content is live streamed via APSC Cloud, APSC Facebook, as well as the YouTube pages. I'd just like to quickly state the objective of today's session. We want to review the evidence for vulnerable plaques in multiple cardiovascular beds. We want to state if current evidence support vulnerable plaques as a risk marker, or is it possible as an interventional target? And we want to, through this series of lectures, narrate how do we actually assess them, where is it really important, and how do we treat it? So I hope my faculty can help with simple and succinct advice to the audience for this session. So let's get started, and we'll welcome Dr. Chin to talk about coronary imaging for ACS to categorize vulnerable plaques. Chi Yang, please.
Okay, thanks Jack for that introduction. So thanks again for this invitation to speak. Today I will be talking about vulnerable plaque by coronary IVUS and OCT. So I think the overarching question is whether these are just purely risk markers or whether they are intervention targets. But before I get there, I'll just show some illustrative pictures of how we can identify some of these plaque by IVUS and OCT. So I am a colleague of Jack's at the National Heart Centre Singapore and Sengkang General Hospital. So what is vulnerable plaque? I think quite simply, or a simplistic view of it is that vulnerable plaque is a type of plaque that is prone to rupture when all intrinsic and extrinsic effects are taken into account. Now, what is vulnerable plaque in the context of intracoronary imaging literature? In the literature, when we talk about vulnerable plaque from the point of view of IVUS and OCT, usually refers to a plaque with unique morphological features, so structural or physical features such as thin cap fibroatheroma or lipid-rich plaque, which is thought to be associated or shown to be associated with clinical events. The problem with using this kind of an understanding or an assessment of vulnerable plaque is that it does not take into account the extrinsic kind of factors that might be involved in influencing plaque stability. But nonetheless, that's what we have. So I've kind of separated or classified vulnerable plaque by intracoronary imaging into these two broad categories. So the culprit lesions, which tend to comprise lesions with plaque rupture or plaque erosion or calcified nodules, and the non-culprit lesions, so the bystander kind of lesions, which may exhibit some worrying features such as thin cap fibroatheroma or lipid-rich plaque. So just to touch a bit about each of these types of plaque. So plaque rupture, this accounts for about 2/3 of fatal myocardial infarctions. Usually there's transmural fissuring of the fibrous cap. This leads to exposure of the thrombogenic material contained within the lipid pool, and this attracts platelets and thrombus formation and leads to acute thrombosis. So this is the kind of plaque that we normally see or normally leads to ST elevation MI. The plaque itself tends to be lipid rich. And you can see this by intracoronary imaging, which identifies a fibrous cap, which is discontinued and with a clear cavity formed inside the plaque. So just an illustrative case, here on the left, we see at the distal left main, there is a flap extending into the osteal LAD. And by IVUS assessment of this area, we can see that there's this flap in the distal left main, which starts to appear. And in the ostium of the LAD, there's this little cavity, this little hole-like structure, which probably contained or used to contain a lipid pool that has ruptured. Now by OCT, you can see obviously similar features. Here you see, I'll just let it play again. So this is in another patient. You see lots of thrombus in the vessel. So you get to the more proximal part of the lesion. You can see a cavity with a fibrous cap. And there is your plaque rupture. So these are the appearances of what plaque rupture should look like on intravascular imaging. Plaque erosion accounts for about 25% of acute coronary syndromes. There's histopathologically, there is a loss of the endothelial lining with lacerations of the intima, but without rupture of the fibrous cap. So the fibrous cap is still intact. Commonly causes NSTEMI and tends to perhaps occur more commonly in patients who are younger and female. The plaque itself tends to be lipid poor. And by intracoronary imaging, we can see this as the presence of thrombus and an irregular luminal surface, but without the presence of an obvious ruptured plaque. So this is a patient of mine again, presented a couple of years ago. He's male. He came in with the anterior MI. You can see that there's a lesion here in the LAD, just after the large diagonal. It contained a lot of thrombus, and after thrombus aspiration, this is what we found. It's a large vessel, so there's still a lot of residual thrombus. But the surrounding vessels are relatively healthy, not a lot of lipidic plaque around. Granted, you can't see through the thrombus to identify whether or not there was a ruptured plaque, but the whole history didn't sound to me like it was consistent with a plaque rupture. So I just treated this patient with DAPT and NOAC. And when I brought him back 6 weeks later and repeated the angiogram and OCT, all the thrombus is gone, and there's no evidence of any plaque rupture or healed plaque rupture beneath. So the most likely, I suppose, explanation for this patient's acute thrombosis is plaque erosion. So rupture versus erosion, are there any implications on treatment? Again, there's no strong or firm evidence for this, But perhaps if you're convinced, or if you're very certain that a certain type of lesion is more likely to be accounted for by erosion, then a more medical approach with antithrombotic alone might be sufficient. Calcified nodules account for a handful of cases of ACS. Again, histologically, there are nodular calcifications with underlying calcium and an overlying fibrin and thrombus. Tends to occur in older patients and CKD patients who have a very high calcium load. By intracoronary imaging, we can see these as protruding superficial spotty calcifications with overlying fibrin and thrombus, and usually with a substantive underlying calcified plate. So as we see on this OCT pullback here, it's a lot of calcium, and then there's that appearance there. So all this is calcium, low intensity, but very well demarcated lesions. And over here, there's evidence of all these protruding elements. These are the nodular calcifications. And by IVUS, we can see similar kind of findings as well. So those are the so-called culprit lesion or lesions that tend to cause or can cause ACS. But quite often when we treat a patient with ACS, we get minor or milder disease elsewhere, which are non-culprit. But they also sometimes exhibit features which may predict higher risk of events in the future. So I guess the first and foremost of them would be the thin cap fibroatheroma, or TICFA. So TICFA is usually characterized by the presence of a lipidic pool and a very thin fibrous cap, usually less than or defined as less than 65 micrometers in thickness. On OCT, this can be identified as such. Usually there's a wide lipid arc of more than 90 degrees. There's the underlying lipid pool, which you can see as this low intensity and highly attenuated signal here, and a cap thickness of less than 65 micrometers. You can't really confidently see TICFA on IVUS because the resolution of IVUS is usually greater than about 100 microns. So you cannot reliably say that the cap is thin. But what you can use is VH-IVUS, virtual histology IVUS, which is not a new technology. It's been around for a number of years now, but probably not so well applied clinically. So virtual histology IVUS surveys the plaque, and based on the ultrasound properties of the plaque, predicts what type of plaque, what kind of constituents make up that plaque. So you can see here, red usually signifies lipid or a necrotic core, white for calcium, and green for the fibrous or fibrofatty kind of tissue. So with VH-IVUS, you get an IVUS image as well as an interpretation of what the plaque is most likely made up of. And if you have a lot of lipid, you have a large necrotic core, which is in contact with the lumen, so no appreciable cap, then that by virtual histology is defined as TICFA. Is this important? Well, the prospect study from 10 years ago showed that if you had TICFA based on VH-IVUS, then you were much more likely to have a major adverse cardiovascular event compared to if you didn't have TICFA at all. And if you had TICFA plus the element of high plaque burden or a small minimum luminal area, you can see that the risk of an event increases. The prospect was a natural history study, as we all know. So, what can be done to reduce events is not answered by this study, but it certainly helps us understand that the presence of TICFA or the presence of high lipid content does predict events further down the line. What else does the identification of TICFA, how else can it help us? Well, in terms of our intervention, if we see TICFA, we try not to land our stent, or we try to avoid landing our stent in an area which is highly lipidic, because that can lead to edge complications like dissections or restenosis later on in the, down the line. There are some small trials showing that perhaps statin therapy can stabilize some of the plaque and perhaps does increase fibrous cap thickness, but none of this is truly conclusive enough for us to adopt it as firm strategy. Lipid-rich plaque is the other type of plaque that of late has gained a little bit of prominence, especially with the Prospect 2 trial, which was a study which was published recently. So lipid-rich plaque is usually identified by near-infrared spectroscopy, or NIRS. So NIRS IVUS, so it's a modality of IVUS which combines the NIRS camera as well. So with NIRS IVUS, you can have the IVUS image as well as an assessment of how likely the plaque is to contain lipid. So the brighter the yellow, the more confident the machine is that there's a lot of that there's a plaque in that segment. If it's red, then it's a lipid-free plaque. So the more yellow you have, the more lipidic the plaque will be. This rectangle here, this red rectangle with these yellow spots, this is the chemogram, which kind of lays out in longitudinal view the distribution of fat or lipid across the vessel. And the more of this yellow, or the more of this lipid you have, is thought to predict a higher event rate. So the LRP study presented or published 2 or 3 years ago now. This was one of the earlier trials for NIRS. So this showed that if you had more lipid identified by NIRS IVUS, you had almost double, in fact, a chance of MACE in 2 years, at 2 years. This was followed up, obviously, more recently by the Prospect 2 study, which again further confirms that the more lipid you have, the higher your event rate is going to be. Also, plaque burden also seem to independently predict a higher event rate, and the combination of high lipid content plus plaque burden further increased that risk as well. Macrophages are another type of structure that we can see on OCT, sometimes more convincingly, sometimes it's not so difficult to identify. But nonetheless, macrophages are seen or have been shown to be seen more in patients with ACS versus non-ACS, in patients with poorly controlled diabetes, and patients where the lesion seems to be getting more and more stenosed. Microchannels, which are tiny little neo vessels which develop as a result of thought to be as a result of plaque rupture and healing, and plaque rupture and healing. These can also these are also a sign that this plaque is perhaps a little more prone to causing an event in the future. So I think it is quite convincing. I think the literature is quite convincing that intracoronary imaging findings do predict or can predict events. The 3 L's, large plaque, lipid-rich plaque, or small lumen area. These are the 3 main elements on intravascular imaging that predict events later on down the line. And these are the trials that back up these findings. So I think I think we can all accept that certain features on intracoronary imaging will predict or do predict events down the line. I guess the remaining question is whether or not we can do anything about it. So what about preemptive PCI? As part of the Prospect 2 trial, there was the Prospect Absorb study. So in Prospect Absorb, patients with ACS after PCI of the culprit lesion had NIRS IVUS performed in all 3 of their coronary arteries. And if NIRS IVUS picked up a lesion with a plaque burden of more than 65%, and in combination with an angiographic diameter stenosis, which was non-significant. So these had to be non-flow limiting stenoses or non-angiographically significant stenoses, or stenoses with a negative FFR. So if you were usually not going to treat these lesions, but there was the presence of a plaque burden of more than 65%, these patients were randomized to treatment with either an absorbed BVS or with guideline-directed medical therapy alone. The follow-up was at about 2 years. All the patients underwent 3-vessel angiography and NIRS IVUS again. And the primary efficacy outcome was minimum luminal area. They also looked at target lesion failure and MACE rates, but these were non-powered for this study. So the concept for Prospect Absorb was that if you had a lesion which was lipid-rich, which was deemed to be vulnerable by intravascular imaging, the idea was that if you put in a BRS or a BVS, the BVS will stimulate some kind of neointimal hyperplasia, which then gives rise to a thicker cap later on down the line, and that thicker cap, could potentially stabilize what was previously an unstable or vulnerable plaque. Whereas if you did not do that, then the plaque might be more likely to rupture and cause a thrombus. So that was the idea behind the BVS implantation. So in Prospect Absorb, about 90 patients each in the two arms. And you can see that at 2-year follow-up, there was an increase or there was a greater minimum luminal area in the patients with BVS versus guideline-directed medical therapy alone. I guess that's not surprising since you stented the lesion in the first place, but it's convincing. It's reassuring, I guess, that even after 2 years, the minimum luminal area was much greater if you had a BVS versus just medical therapy. And this was not just at the minimum. This was not just at the original MLA site, but also across the entire lesion. In terms of clinical events, MACE rates, guideline-directed therapy alone did seem to have a greater event rate compared to if you had put in a absorbed BVS, but this is non-significant because the trial wasn't powered to show this. Also, as part of their presentation, the Prospect Absorb team showed a few illustrated cases. This is one of them. So this is a patient who had a lot of lipid in the original angio and original nearest IVUS pullback. A BVS was implanted, and at follow-up, it seemed like the lipid was gone. Whether that lipid was truly gone or not, or whether it was just the machine's inability to pick it up now that there's the presence of a scaffold or a healed scaffold is unknown. And so this phenomenon, although they showed it, they admitted that they weren't sure what was the proper explanation for it. So Prospect Absorb, in summary, it was promising, I guess, in showing that BVS implantation in angiographically non-flow limiting lesions or non-culprit lesions, but with high-risk plaque features, was safe and did enlarge the luminal dimensions at follow-up. But the trial was not powered for clinical outcomes, so we don't know whether clinical outcomes were truly reduced or not, although there was a trend towards that. But I think what the authors summed up was that these findings are encouraging for the performance of a larger, properly powered clinical trial. And perhaps, this with future iterations of BVS beyond this first generation BVS, and with the use of contemporary thin thread DES, perhaps the results will be even better if there was a proper clinical trial. So as I kind of alluded to earlier, what are the limitations of intracoronary imaging in assessing vulnerable plaque? Usually we only base it on still frame analyses for physical structure. There's no appreciation of the extrinsic factors that may be involved in plaque stability, such as shear stress, the interdependence between tandem lesions, and other systemic kind of situations such as the coagulability of the patient, inflammation. So it's imperfect to just try and predict things just based on imaging alone. And I lifted this picture from this review by Stefanidis in 2017. It's just a conceptual kind of plot showing that there is not just just the intrinsic plaque architecture alone doesn't predict or shouldn't predict the possibility for a plaque to rupture. There has to be extrinsic effects which influence it as well. But perhaps our understanding or our interpretation of vulnerable plaque is a little bit too simplistic when it comes to intracoronary imaging. So anyway, in summary, there are many types of vulnerable plaque that can be observed by intracoronary imaging. Identification of vulnerable plaque does, I hope everyone is convinced, does predict higher event rates in non-culprit lesions. But the strategies that we can adopt to reduce these events are still unknown and probably require more study. And perhaps, as a more broad kind of a concept, attempting to base judgment of plaque vulnerability purely on the presence or absence of certain phenotypes neglects other extrinsic factors that may play a role in influencing plaque stability. That's all I have. This is just a plug for Singapore Live next year. Thank you very much.
Thanks, Chi Young. That was indeed a wonderful lecture that you just gave. Now, maybe we just take a pause here for 5 minutes for a quick Q&A before we move on to the next lecture. I'd like to ask Paul, actually. Paul, you heard the lecture. I thought it was very good. There are 2 points brought up. In the ACS setting, if you do see a suspicion of erosion rather than plaque rupture, is that your practice? Do OCT, decide on medical therapy rather than lay a stent? Then the second question is, if you do see on the way when you do that, TICFA or lipid-rich ThinCat, is this convincing enough for you to put longer stents across it? Paul, please.
Well, I have to admit that during the ACS setting, maybe IVUS is a more practical tool for us, because obviously if you are doing an ACS and the flow is obstructing or semi-obstructive, then the OCT initial image will not be good. And here in Taiwan, we cannot afford to have both the IVUS as well as the OCT for the same patient in the same setting. So I would say, based on the IVUS, it's difficult to appreciate TICFA, but rather a flap or erosion, thrombus existing. So basically, I think in the setting of ACS, we are still relying on the IVUS features of an unstable plaque or vulnerable plaque, and then we will decide from that. In that regard, to put in longer stent than we needed from the IVUS judgment would be a rare experience for us. To have a OCT after initial clearance of the thrombus, and then to look for the treatment strategy, again, is a rare experience for us. So Jack, you have set up a very good theme for this webinar, that the vulnerable plaque, whether it's an indicator or a treatment target, is still under debate. And I think the previous presentation have also shown us that we have some evidence showing that we have to be more aggressive on these vulnerable plaques. But which treatment modality or the actual practice is still under investigation. I think that's my opinion.
Thanks, Paul. Can I ask whether the panel has any other questions for Chi Young first? Any questions for Chi Young?
I think Chi Young had brought up a very interesting point. That is, it's not only the plaque itself in terms of imaging phenotype that matters, but these extrinsic factors, such as the location of that lesion, and also the overall biochemistry that is happening at the setting. I think these are also very important features that you have to take into consideration.
Thanks, Carl. Again, great comments. Chi Young, can I just check you then? You're giving a lecture. What's your own personal view of how we should practice based on imaging in the acute coronary syndrome setting?
I think, of course, I showed a case where I deferred stenting based on what I thought was plaque erosion. There were obviously other considerations as well. At that time, it was very near a side branch, etc. So I would still say it's very rare that I, being honest, very rare that I would be confident enough to defer what is our conventional way of treating a culprit lesion. So I probably would still, in general, for a culprit lesion, stent it. For non-culprit lesions, I don't know. I wouldn't preemptively treat them. I think if in that example you asked Dr. Kao earlier, if there was vulnerable plaque or TIGFA very near the edge of your culprit lesion, yeah, sure, maybe you might extend your stent a little bit just to cover it. But otherwise, yeah, I don't know. I think I wouldn't stent it, but certainly you would probably counsel the patient and say that, look, you still have these the presence of these other areas where there are features of plaque vulnerability. You really need to look after yourself. Statin must be taken, etc. And kind of forewarn them that might be another event later on down the line.
Thanks, Chiang. So just a quick recap. I think we all hear the hesitation to act on it. So I think currently my summary I'll take based on your lecture is that it's still more a risk marker. It does prompt us to be even more aggressive in declared diseases like this in terms of risk factor management. Whether you stent it or not, I think it's still a judgment call. The evidence currently probably doesn't support it. So we're going to move on to stable subset now. Simonet is going to present to us on categorization of vulnerable plaques based on imaging in a stable coronary artery disease subset. Simonet, please.
Thank you, Dr. Jack, for that kind introduction earlier. I will share my screen now.
Yep.
Okay. So thank you to the APSC for inviting me to be a speaker in this Cloud Forum series. I have nothing to disclose, and my talk today will focus on high-risk plaque imaging with coronary CTA and coronary MRI, its prognostic value, some advances in CT and MR plaque imaging, and of course, the vulnerable patient. So as we know, atherosclerosis is an inflammatory process that affects the arterial intima with extensive lipid deposition, foam cell formation, and vascular smooth muscle cell migration. The resulting plaque formation can lead to progressive arterial narrowing, ischemia, and symptoms of stable disease or stable angina. The plaque can also rupture, resulting in thrombus formation, vessel occlusion, and myocardial infarction. As mentioned earlier, aside from plaque rupture, acute coronary syndromes are also caused by plaque erosion, underlying between 25 and 60% of acute coronary syndrome. This figure shows the progression of coronary atherosclerosis and luminal narrowing. As we know, plaque progression leads to the formation of fibrous cap atheroma and a thin cap fibroatheroma, which may result to plaque rupture and thrombosis, or plaque erosion and thrombosis, followed by necrosis and calcification. Also mentioned earlier that the vulnerable plaques are the lesions with the greatest risk of rupture. This is also known as the high-risk plaque, or HRP, which has a large necrotic lipid core, a thin fibrous cap, inflammation predominantly in the form of macrophage infiltration, neoangiogenesis, intraplaque hemorrhage, and microcalcification. Now, these characteristics are frequently found together and each represent a potential imaging target. CCTA detects the different stages of atherosclerosis as well as the severity of obstructive CAD and can guide clinical decision-making for secondary prevention. Those patients with high-risk plaque features are already at least moderate risk of ischemia, ACS, or major CAD events. Calcium score has been around for some time, and it's been used as a surrogate marker of atherosclerotic plaque burden. It also provides a powerful CV risk prediction in addition to traditional CV risk factors or scores. However, macrocalcified plaques that are detected on calcium scoring are generally considered more stable and hence relatively unlikely to rupture and cause myocardial infarction directly. And thus, plaque imaging and CV risk prediction may actually be improved by considering not only the total plaque burden, but also the plaque type. High-risk plaque features, or HRP features that are found on CCTA are the following. The first is positive remodeling, and this is represented by the red line. which is defined as an outer vessel diameter, which is 10% or greater than the mean diameter of the normal adjoining segments, represented by the blue line. The next is low attenuation plaque, or LAP, represented by that dark or hypodense area between the red and the blue line. And this is defined as a central focal area within the plaque, which shows a low CT attenuation of less than 30 Hounsfield units. As a reference, these are the CT attenuation Hounsfield units, values of dense calcium, fibrous plaque, fibrofatty plaque, and the lipid necrotic core. Another HRP feature is spotty calcification, and this is represented by that small bright dot that you see within the non-calcified plaque, which is outlined in red. This is defined as the presence of small calcifications, focal at that, which are less than 3 millimeters in diameter in any direction. Last is the napkin ring sign, which is defined as a central area of hypodense or dark or low CT attenuation that abuts the lumen, plus a ring-like hyperdense or higher attenuation plaque tissue pointed in yellow surrounding this low attenuation area. Here are representative images of the HRP, or high-risk plaque. The left panel is a curved MPR reconstruction of the RCA, showing mild calcified plaques in the proximal segment, followed by a critical lesion in the mid-RCA caused by a predominantly non-calcified plaque pointed in yellow. If you see in the central panel, this is a stretched reconstruction in a magnified view showing the same lesion pointed in yellow that appears to expand outward, demonstrating positive remodeling. The right panels are cross-sectional images of the same lesion showing significant narrowing of the lumen, represented by L, or the letter L. And the napkin ring sign, as what I mentioned earlier, is a low attenuation or hypodense core and surrounded by a high attenuation or hyperdense rim. The LAP suggests the presence of a lipid necrotic core, and the napkin ring sign suggests the presence of a circumferential necrotic core correlating with histology. This slide is from Lee et al. And the investigation of the paradigm study. It illustrates the progression of non-obstructive lesions with and without HRP from a patient with stable CAD. Total plaque volume from the color mapping that you can see over there, diameter stenosis, and high-risk plaque features, which you can see in the stretched curved MPR images, are seen here on baseline CCTA and again on follow-up CCTA after about 2 years. A plaque, or the plaque in the LAD with high-risk plaque features at baseline remained non-obstructive at follow-up. However, the plaque in the RCA that did not have high-risk plaque features progressed into an obstructive lesion at follow-up. The total plaque volume and the diameter stenosis were also greater in the RCA lesion that did not have any high-risk plaque features compared to the LAD lesions with HRP features. Now, just to mention, the paradigm study is a multinational prospective registry of patients with clinically indicated CCTA at least 2 years apart. And the results of that study show that baseline percent atheroma volume and not the presence of HRP features was the most important predictor of lesions developing into obstructive lesions. Okay, so this is a case of a 50-year-old female hypertensive smoker with atypical chest pain who was referred to me for CCTA, 3D volume rendered reconstruction on the right, and curved MPR image of the LAD in the center panel shows a calcified plaque in the proximal LAD with less than 50% stenosis, followed by non-calcified plaque after the second diagonal artery, pointed by the yellow arrow and the yellow line. As you can see in a magnified lumen view of the mid-LAD, high-risk plaque features are seen. There is positive remodeling, and the low attenuation plaque measured at 23 Hounsfield units. This lesion was called as this lesion in the mid-LAD was called as 50 to 70% stenosis. Maximal medical therapy and lifestyle changes were initiated for this patient. She remained stable and asymptomatic. However, 1 month after she had recurrence of symptoms, and myocardial perfusion imaging apparently showed inducible ischemia in the LAD territory. Elective coronary angiography was done, which showed a 60 to 70% stenosis of the mid-LAD. This is in comparison to her previous CCTA, showing a 50 to 70% stenosis. I do not have the images here, but successful IVUS-guided PCI of the LAD was performed. So what is the prognostic value of HRP in patients with stable CAD? In a large study of patients followed for about 4 years by Motoyama et al., the presence of HRP, specifically positive remodeling and low attenuation plaque, was associated with an 8-fold increase of subsequent ACS. In the PROMISE trial, the presence of HRP, specifically plaque, positive remodeling, low attenuation plaque, or the napkin ring sign, was associated with a 70% increased risk of MACE at 2-year follow-up. Predictive value of HRP was strongest in the younger patients, in women, and in those with non-obstructive CAD. In a secondary analysis of the Scott-Hart trial published in JACC 2019, investigators looked at prognostic implications of adverse plaque, which was defined as either positive remodeling or low attenuation plaque. And they looked at patients with suspected CAD who were followed for 5 years. So results showed that coronary heart disease death or non-fatal MI was 3 times more frequent in patients with adverse plaque, represented by the red line, as compared to those with no adverse plaque, represented by the blue line. The bar graph on the right demonstrates the frequency of CHD death or non-fatal MI at 2 years, represented by the blue bar, and at 5 years, represented by the red bar. And these were for patients with normal coronaries, those with non-obstructive CAD, and those with obstructive CAD, with and without the presence of adverse plaque. Patients with both obstructive disease and adverse plaque had the highest event rate, with a 10-fold increase in CHD death or non-fatal MI compared with patients with normal coronaries. These findings suggest that although plaque composition and its hemodynamic consequences are associated with future MI, the predominant factor governing patient outcomes is actually the burden or the total plaque burden, or the burden of coronary atherosclerosis. In the low attenuation plaque sub-study of the Scott-Hart trial, quantitative analysis of the low attenuation plaque revealed that the LAP burden was the single greatest predictor of incident MI. The optimum threshold for LAP burden was 4%. The presence of LAP burden more than 4%, represented by the red line, was associated with a nearly 5-fold increase in the hazard for myocardial infarction. Among patients with non-obstructive CAD, an LAP burden more than 4% was significantly predictive of incident MI, but no increase in risk was noted for those with non-obstructive CAD and a LAP burden or LAP burden of less than 4%. What about the effect of statins on coronary atherosclerotic plaque? Well, in the PARADIGM study, patients underwent baseline CCTA and follow-up CCTA at about 3.8 years apart. The bar graph shows that statin-taking patients, represented by the green bars, displayed a slowed rate of progression when compared with statin-naive patients, represented by the orange bars. There was a 23% increase in calcified plaque volume. However, the non-calcified plaque volume decreased by 54%. On the left panel, you can appreciate these changes in the curved MPR and lumen view of CT images, where the white areas represent calcified plaque and the green areas represent the non-calcified plaque. So whether calcified or non-calcified plaque, the overall annual PAV change, or percent atheroma volume change in percentage per year, increased by 1.76% for statin-taking patients as compared to 2.04% for statin-naive patients, with a p-value of 0.002. A similar pattern was noted for non-calcified plaque volume. However, despite exciting research showing the utility of imaging plaque progression, current evidence is still insufficient to support a clinical recommendation for serial CCTA imaging. Now, the Society of Cardiovascular CT and North American Society of Cardiovascular Imaging came out with their updated expert consensus for coronary CT imaging of plaques, which was published early this year. And the summary statement on risk assessment with CCTA findings involving high-risk plaque is as follows. So, high-risk plaque characteristics are associated with ACS and future MACE. Now, the best overall agreement, however, because of inter-observer variability, is really the identification of positive remodeling. There are softwares that are new softwares that are being that are advanced and are still being used in research. Automated quantification of atherosclerotic plaque is available, but at this time is still investigational. I think importantly, and they say this in their statement, although we can risk stratify with high-risk plaque, directed interventions are not yet defined. We need additional data as the positive predictive value of HRP is still variable when compared with the comprehensive total plaque burden measures such as that obtained by calcium scoring. And as we know that high-risk plaque is a dynamic process and likely to change over time. Now, we now proceed with coronary MRI imaging techniques. Now, these techniques are actually less well developed than coronary CT and is not in widespread clinical use. And this is because the technique can be relatively challenging due to the small size of the coronary arteries and as well as cardiac and respiratory motion artifacts. Having said that, an imaging sequence called non-contrast T1 weighted imaging allows the detection of plaque, which appears as a bright or hyperintense signal, and this is termed high-intensity plaque or HIP. On the left panel, you can see a normal coronary MRA in an HDL view. You can appreciate that the coronary origins are normal and the visualized coronary segments are patent. The image in the center is a non-contrast T1 weighted imaging eggshell view at the level of the LAD. And here you can appreciate that bright signal or high intensity signal in the proximal LAD that is pointed in yellow. This suggests the presence of a high intensity plaque or HIP, and images obtained from T1 weighted imaging are actually co-registered with MRA imaging seen on the right panel, which also shows increased signal at the site of the high intensity plaque pointed in yellow. Now, we try to compare these two imaging modalities in terms of assessment of the vulnerable plaque. So illustrated here is a vulnerable plaque, which is either high-risk plaque or HRP, or the high-intensity plaque, HIP. This is in the same patient on both CCTA and CMR imaging. Non-contrast T1 weighted imaging in a coronal view on the right panel shows the left ventricle, the aorta, and a high-intensity plaque in the distal RCA, which is pointed in white. The high-intensity plaque in the distal RCA is visualized as a low attenuation or low-intensity plaque in the distal RCA on CCTA images pointed in white on your right panel. Magnified images of the hip on T1 weighted imaging and the lap on CCTA imaging are shown in the upper right corners of your screen. In terms of prognostic value of HIP, based on CMR imaging, non-contrast T1 weighted imaging provides important prognostic information. Here are representative images of the same patient with HIP in the proximal RCA, as you can see in the center panel, pointed in yellow. And this corresponds to an intermediate stenosis with positive remodeling in the proximal RCA, as seen on CCTA on the left panel, pointed in yellow. This patient subsequently developed acute coronary syndrome with an occluded proximal RCA on coronary angiography that's seen on the right panel. Now, in a large study by Noguchi et al., coronary HIP was seen in 159 patients out of 568 patients with known or suspected CAD. HIP was quantitatively assessed by measuring the PMR ratio, or the plaque to myocardium ratio. And they followed these patients for a median of about 55 months. Coronary events were observed in 55 out of 568 patients. A PMR, or plaque myocardium ratio, of 1.4 was identified as optimal cutoff for predicting cardiac events. There were 4 groups that were evaluated. Among the 4 groups, based on the PMR cutoff of 1.4 and the presence of coronary artery disease, coronary event-free survival was lowest in the group with a PMR of 1.4 or higher, plus coronary artery disease, as shown in red, and coronary event-free survival was highest in the group with a PMR of less than 1.4 and no CAD, shown in orange. Interestingly, the group with a PMR of 1.4 or higher and no CAD, which is shown in the green line, had an intermediate level of survival, which was similar to the group with a PMR of less than 4 plus CAD, shown in the blue line. Multivariate analysis identified the presence of a PMR of 1.4 and higher in terms of the plaque myocardium ratio as a significant predictor of coronary events compared with the history of CAD and other traditional risk factors. So what are the current advances in CCTA? One that was presented at the SCCT last year was a CCTA Fat Attenuation Index. This is a promising novel technology in CCTA. The software that was developed by Oxford University and allows the visualization and quantification of vessel inflammation rather than relying on visualization of a plaque in the vessel. The rationale is that coronary plaque inflammation alters the composition of the adjacent epicardial fat. And this effect can be detected by changes in CT attenuation. So you can see here a healthy, non-inflamed coronary artery has a low fat attenuation index. And you can see below in the color mapping, there's a homogeneous yellow color. 3 years later, the same patient has an MI, and now the coronary artery is inflamed with a high fat attenuation index, as seen by the color mapping, which now shows heterogeneous red to orange color, which codes for an attenuation of at least negative 30 Hounsfield units. Okay, so there is also that technique together with the FAI index, which is called the FAI mapping. Okay, so perivascular FAA mapping, the top panel shows a 3D volume rendered reconstruction and curved MPR images of the coronary arteries, the RCA, the LAD, and the LCX. Perivascular fat attenuation mapping was done by tracing the proximal 40 millimeter segments of the RCA, LAD, and LCX. Now, the the fat attenuation index is quantified based on the color-coded Hounsfield unit attenuation of perivascular fat, which ranges from negative 190 Hounsfield units to negative 30 Hounsfield units, corresponding to the color yellow to orange to red. The bottom panel shows a magnified view of the proximal RCA in the center image and the corresponding view on the image on the right. So the light gray area that you see represents the contrast-enhanced vessel lumen and wall. Adjacent to this vessel is the surrounding perivascular fat. No, that's the perivascular surrounding fat is within a radial distance from the outer vessel wall, which is equal to the diameter of the vessel in question. The red to orange color-coded overlay indicates perivascular inflammation. So the CRISP-CT study in the group of Dr. Antoniades performed an analysis on CCTA scans from 2 independent and diverse cohorts in the CRISP-CT study. A high FAI index was a value of negative 70.1 Hounsfield units or higher, represented by the red line. Low FAI was a value of less than minus 70 Hounsfield units, represented by the blue line. Over a median follow-up of 60 and 48 months, respectively, elevated perivascular FAI was independently associated with a higher risk of all-cause and cardiac mortality in both cohorts. Higher FAI values were linked to an almost 9-fold and a 5-fold higher risk of cardiac mortality in the derivation and validation cohorts, respectively. These findings highlight perivascular fat attenuation index as a new dimension in CCTA, which can guide the deployment of appropriate interventions in both primary and secondary cardiovascular disease prevention. For example, which patients do we put on aspirin? Which patients do we put on statins? And this also includes the potential for monitoring reversal of coronary inflammation using various drugs. Advances in MR imaging include nanotechnology and molecular imaging of atherosclerosis. I won't go through all the further details on this, but nanoparticles represents a versatile platform or targeted molecular imaging of different molecules that are expressed in the atherosclerotic plaques. So what happens is the distribution of these contrast agents can be traced precisely to the atherosclerotic lesions, and the signal intensity can look different based on the different modalities, whether it's MRI or PET imaging. And these signal intensities can be increased with nanotechnology and molecular imaging. I think what's really important is not to forget the vulnerable patient. So in clinical practice, we cannot overstress the importance of identifying the vulnerable patient, as well as risk stratification for those who are at higher risk of future major adverse cardiac events who would benefit from intensive treatment in both primary and secondary prevention. We know that the more the presence of risk factors, the more the risk factors, the higher the risk for CVD. And we also know, based on what has already been discussed, that plaque rupture, plaque erosion, calcified nodule, and functional coronary alterations represent pathophysiological mechanisms underlying acute coronary syndrome. It seems that the combination of the high risk or vulnerable plaque and the vulnerable patient phenotype are likely required to produce an adverse cardiac event. Having said that, is the HRP or high-risk plaque on CT and MR imaging a risk marker or intervention target in stable CAD? Well, I've showed you the evidence that's out there, but in my opinion, I think yes, it is both a risk marker and an intervention target. So in summary, CCTA and CMR have the ability to non-invasively detect the vulnerable or high-risk plaque. High-risk plaque characteristics are associated with acute coronary syndrome and future MACE. Although we can risk stratify patients with HRP, directed interventions are not yet defined and additional data are required. The combination of the vulnerable patient and high-risk plaque are likely required to produce an adverse cardiac event. And that's my last slide. Thank you for your attention, and thank you and congratulations to the APSC and the organizing committee.
Thank you very much, Simone. That was really a very comprehensive lecture that you just shared with us. In the interest of time, maybe we just have one quick question. So my question to you is this: I think the current practice a lot of people do, there's cheap, fast, and dirty, is a calcium score. Is a calcium score equally predictive versus a CTA, you think, and other forms of imaging for risk stratification?
Yes, and you're correct. It's cheap, it's fast, and you can right there and then determine if the patient needs to be placed on statins, because a lot of times patients don't want to take statins. They just prefer to take their hypertensive meds or their diabetes medicines. Having said that, we all know that the only way to quantify total plaque burden is really from the coronary calcium score. But having said that, we only visualize the macrocalcified or the hard plaque. We don't get to see the non-calcified or low attenuation plaque, which is a feature of a high-risk plaque. but it's a quick and fast way to risk stratify patients. For example, if you thought the patient was low risk or intermediate risk and their calcium score is positive, then the patient is reclassified to intermediate or high risk.
So I
Yeah,
think the
and
medical guidelines do use it as a risk enhancer, I think, to push up for primary prevention therapy.
correct.
Your point is well taken. We have to be careful in use in extremely younger patients, I think, not to miss the soft plaques. I think we do have to move on to the money lecture. Is there anyone with any other questions for Simonet? If not, I think we'll transit to Zazali next, where the money is. How do we use optimal medical therapy for vulnerable plaques? Zazali, are you ready?
Hi, Jack. Thank you very much. Just let me set up here. Hey, guys. Thanks, Simone, for flashing that last slide, which merged very nicely to my talk. And it's a good note to finish because you were mentioning about the actual therapies that we can use to direct against this potential vulnerable plaque. And what I need to stress out here is, probably in the interest of time, what we really should be focusing on as cardiologists and physicians is on the smoking, diet, exercise, the stress, the socioeconomics factor, the boring bits. But as we have it, normally we'll be talking about the pharmacology and devices in terms of treating our patients. There are vulnerable patients resulting in vulnerable constituents of the blood vessel, either plaque or thrombogenesis, or crystals, resulting in prolonged inflammation and sedimentation of highly oxidized lipids, developing into atherosclerosis. So I'll be going through a bit of those. So I'll start with a clinical case. A 25-year-old Malay boy who's never been ill before, presenting with an anterior STEMI, brought in for a prime PCI and successfully stented. And as you can see in the picture on the right, top left, the square on the right side, he still has residual disease down his LAD, and his circumflex doesn't look entirely normal as well. His LDL when he presented was 12, and we worked him out for possible FH, and he turned out to be a definite FH. And initial therapy was with Rosuva 14 and ezetimibe. And once his funding was cleared, he was given Atherosclerotic for about 6 months. And subsequently, his LDL improved quite markedly. And he was lost to follow-up, and his funding ran short. He was not able to access Atherosclerotic anymore and was maintained on Rosuva and ezetimibe. On the bottom left, interestingly, his LDL was still maintained at low levels despite being off his PCSK9 inhibitor. But subsequently, after about 3 years, represented with exertional angina, and the lesion in the circumflex had progressed. So despite having very low cholesterol levels, this young guy went on with a family history of familial hypercholesterolemia to develop further lesion. So the question is how many of these patients are there actually floating around, being treated, but still having excess residual risk of developing events? So residual risk is described as once you have all your risk factors corrected, your LDL below 1.8. However, these patients are still prone to getting recurrent myocardial infarction, angina, hospitalization, or even death. So from the clinical trials from Prove It, where different doses of statins were compared against each other, and Improve It, adding in ezetimibe on top of statin therapy, the percentage of residual risk patients was about 30%, which may be overestimating because these are clinical trial patients. When they look at the American registry, from the Virgo registry, patients who are classified as residual risk was around 16%. So what can you do? Are there any therapies that are effective against them? When we talk about atherosclerosis, it's a progressive, continuous process. We all know that it starts at a very, very young age, even in utero. And there are many, many factors that drives the formation of atherosclerotic plaque. Current guidelines, we tend to catch them quite late, As you can see in the second row, once we have diagnosed them with atherosclerotic disease, either in the coronaries or elsewhere, then we consider starting them on secondary prevention and classifying them as high-risk patient. But ideally, we should be able to detect them fairly early to try and prevent these patients from developing disease, extending the concept of primary prevention. We all know that statin works, either via primary prevention trials, which is a solid dark blue line that you see at the bottom, from the West of Scotland cardiovascular outcome using pravastatin, to the American AFCAP study using lovastatin, as well as ASCOT trial. We can see that the lower your LDL is, the lower your risk of developing event would be. In the primary population, the slope is gentler, milder, because the patients are technically low risk, not having a disease in the first place. In the secondary prevention, patients who are post-infarct, post-myocardial infarction, the magnitude of risk reduction is greater when you commence them on any statin, either simvastatin, atorvastatin, pravastatin, and right down to high-dose atorvastatin, which is a PROVIT trial, bringing down their risk reduction to very, very low levels. And we all know this slide by Brian Ferentz, which shows the causality association of LDL and atherosclerotic disease. What he did was showing it up as a Mendelian randomization. That concept pretty much means that if you're born with a genetic mutation to a gene that results in very low LDL, and you're to compare it to somebody who's born with a normal gene resulting in normal or high LDL, and you map out their outcome over time, and you can see here that those who are born with mutation in the LDL receptor, resulting in very, very low LDL cholesterol values, has the most maximum risk reduction in developing event. And because it's a genetic mutation and patients are being followed up for such a long time, the median follow-up is 52 years compared to randomized clinical trial where the average follow-up is about 5 years. So there is very strong causal link that says that LDL is associated with cardiovascular events. Bringing LDL down with any therapy will reduce your risk of developing cardiovascular events. The next question is it due to the regression of plaque volume, reducing percentage stenosis in culprit lesion, plus other vasculature, or is it through other mechanisms that is actually driving the atherosclerotic process itself? So we now know that it's a combination of both. When we look at the more recent trials, such as using PCSK9 inhibitor, the magnitude of reduction in terms of risk is right smack in line with the other studies using a statin, high-dose statin. And here, the concept is that the longer you follow up the patients in a clinical trial, being on treatment, being monitored, and the adherence is fairly solid, the magnitude of risk reduction would be much greater. So for the Fourier, Spire, where the follow-up is 1 or 2 years, the risk reduction for cardiac events, being myocardial infarction and stroke and primary composite endpoints, were about 17%. How does this change the appearance of the vasculature? Do they actually change? Do they actually get better? Do the ulcers heal? In the carotid intima from the METEOR study, they look at the rate of change of maximum intimal medial thickness at 12 carotid sites, comparing rosuvastatin versus placebo. And in the placebo, where they are not treated with statin, as expected over a period of 2 years, there is increased thickening of the carotid intima. Now, the procedure is fairly well controlled. The person who's doing it does it over and over again, so there's very little inter-observer variability. What they found was that those patients who were given rosuvastatin 40 milligrams did not have progression of plaque and showing signs of plaque regression. However, when it went through FDA, the percentage magnitude was not convincing enough for them to suggest that it should be used as a indicator to regress plaque in patients with atherosclerotic disease. When we're monitoring for endpoints via imaging to look for vulnerable plaque, there are two criteria that can be used, i.e. either angiography-based definition, looking for either increase in plaque progression, increasing percentage stenosis, or regression, or by, as Dr. Simone have very eloquently explained, plaque-based definition, the presence of low attenuation plaque, increase in plaque atrophy volume, and the presence of necrotic core. Here's a very nice study that was done from Korea by Seung-Joon Park. It's called the STABLE trial, published a few years ago, where they look at 312 patients who were admitted with an acute coronary syndrome or indicated for percutaneous intervention and have at least one vessel, one non-culprit vessel not performed during the procedure, and VHI was performed on these vessels, and follow-up was done at 12 months. And patients were randomized to receive either high-dose rosuvastatin or low-dose rosuvastatin, either 10 or 40 milligrams. And what they found was that in patients who was given high-dose rosuvastatin, the coronary artery has changed in terms of the content of fibrofatty content as well as necrotic core. However, those patients who had elevations in their high sensitivity CRP levels responded better to statin therapy and showed better improvements in terms of disappearance of necrotic core during their follow-up. And this can be seen again, the picture on the left, where you see a cross-section of a VH at baseline and at 12 months, showing a patient who has regression of vulnerable plaque features, and the bottom picture showing a picture at baseline where the patient actually progresses in terms of feature of vulnerable plaque. And again, this is to stress out that inflammation plays a big role. Despite having similar LDL reduction, it doesn't really correlate to the degree of disappearance of necrotic core or dense calcium, but it's actually the degree reduction of CRP improvement on statin therapy that could actually predict whether or not the vulnerable plaque features disappears over time. This is a study using PCSK9 therapy. It's called GLAGOV. It's a sub-study of the FOURIER trial where patients who post myocardial infarction randomized after being on statin to either placebo or evolocumab given at a monthly basis and followed up to about 5 years. And what they try to see is that they are looking at the differences in plaque volume in the coronary artery. And what they found was that there is a very significant reduction in LDL cholesterol, which is to be expected when you're given PCSK9. But in both groups, there wasn't much reduction in terms of your hsCRP because it's a lower risk population. The mean average CRP here was about 2.3. Hence, they did not find much changes in terms of the improvement in terms of vulnerable plaque, despite the trial showing a significant risk reduction for outcome. And that outcome that was pertinent here was pretty much driven by myocardial infarction and recurrent stroke, giving a significant reduction by 17% for the composite endpoints. So from the GLAGOV study, what can be concluded is that combined therapy with statin and PCSK9 inhibitor, evolocumab, lowers LDL cholesterol, which is fantastic, promotes plaque regression, while increasing plaque calcification. This is what they saw, suggesting plaque stabilization. So this picture on the right, you can see that as your cholesterol value drops from 110 to as low as 20 and 30s, this is 0.2 millimoles, you have an increase in plaque calcification. However, if your cholesterol were to not be controlled and actually allowed to rise up to 90 to 110 milligrams per deciliter, you have an increase in percent atheroma volume as described before, a marker of plaque vulnerability. So favorable reductions in necrotic core were observed in patients demonstrating marked degree of plaque regression, and VHI-IVUS imaging was unable to detect any plaque composition differences between the group, presumably because the hsCRP levels were quite low. I'm still not sure about that. Sorry, Siri. This concept of inflammation went back to more than 20 years ago. This is a slide from the Physician Health Study done by Paul Ricker, one of the bigger names driving inflammation and LDL trials globally. And what we see here is that as the quartile of CRP rises, your risk of developing myocardial infarction increases. This is in healthy men. And subsequent to that publication, many meta-analyses have been performed. And over again, hsCRP concentration is associated with the incidence of developing coronary heart disease. So much so that if you were to look at the standard deviation contributing to the presence of coronary artery disease, hsCRP is a greater risk predictor as compared to total cholesterol, non-HDL-C cholesterol, and systolic blood pressure. It's important to know how and where CRP is being produced. CRP is an end product which is being produced by the liver, a marker of inflammation. When we are talking about high sensitivity CRP, we are relating to values of less than 1, which is very low, and values of more than 3, which is considered as high vascular risk. It's a byproduct of the NLRP3 inflammasome pathway, which sits in the mitochondria and is activated by cholesterol crystals, neutrophil extracellular traps, atheroprone flow, as well as hypoxia. Triggering this system will result in the production of interleukin-1 beta, which subsequently converts to interleukin-6. And we have seen publication using drugs such as anakinra, canakinumab, which I'll go into a bit more detail, as well as colchicine, that augments and reduces the values and levels of interleukin-1 beta, resulting in better outcome. Activation of this pathway, of the cytokine pathway, results in pretty much vascular healing, where you have increased smooth muscle proliferation, macrophage activation, increase in adhesion molecules, cytokines, and interleukin-1 system. However, disproportionate excretion of the activation of the cytokine pathway will subsequently result into vascular inflammation, endothelial dysfunction, and atherosclerotic vascular disease progression. One of the trials called Jupiter, which we're all aware of, is quite interesting. It's a statin trial, but instead of randomizing people between low dose and high dose statin, what they did was they subselect population who have low levels of cholesterol, an LDL-C of less than 3.6 millimoles per liter, but who have elevated CRP, CRP of more than 2. CRP more than 2, but without the presence of infection or cancer or anything else that could drive up the CRP. So the whole idea is to select patients who are vascularly inflamed with well-controlled LDL and to randomize them to rosuvastatin 20 milligrams or placebo and follow them up for about 2 years. 8,901 patients was randomized to the rosuva arm and the same to the placebo arm. And what they found was quite staggering risk reduction in terms of events for patients being on rosuvastatin 20 milligrams per day, giving you a number needed to treat to prevent one event at 2 years of 95. And if you were to treat at 5 years, the NNT comes down to 25 patients. So the take-home message from Jupiter was that high-risk patients have improved cardiovascular outcome when treated with rosuvastatin, provided that they have the presence of inflammation with elevated CRP. And similarly, we can see improvement in terms of the rate of stroke, all stroke, as well as ischemic stroke. So CRP here is now taking center stage. as a target for improving vascular health and to treat and target vulnerable plaque. CANTOS was a trial published in 2017 using canakinumab at 3 different doses, and CANTOS pretty much a monoclonal antibody targeting IL-1 beta inhibition, therefore reducing the inflammation and cytokine response. And the picture on the bottom left shows the differences to outcomes, whether or not, if you're on placebo, the red bar, or whether you were treated with canakinumab at various doses. From this study, we know now that canakinumab 150 milligrams given every 3 monthly gives you the most risk reduction to develop an event. So what is interesting is that this is one of the first large randomized controlled trial with thousands of patients showing the benefit of treating inflammation and not targeting LDL itself. So it changes the landscape where just by targeting inflammation, you get a 15% or 21% risk reduction of cardiovascular mortality, which is a very, very strong outcome to achieve comparing to the previous Jupiter study, where the endpoints seen were mainly driven by myocardial infarction and stroke, giving you a positive composite outcome. And from the CANTOS study, in terms of all-cause mortality, you can see a reduction as well. So the outtake from CANTOS is that canakinumab 300 milligram led to a 67% risk reduction also in incident lung cancer, simply due to the fact that it suppresses IL-1 beta, which is an anti-inflammatory and reduces cancer growth. However, you do find more leukopenia and fatal infections with this therapy, giving rise to a bit of fear, as well as it is a drug that is quite costly. So is there any cheaper options out there? Yes, there is. There's a drug called colchicine that we commonly use for the treatment of gout. In Southeast Asia, I think especially in Malaysia, gout is quite rampant, probably due to the diet. How it works is that it inhibits mitosis as well as microtubule formation, which results in reduced excretion of VEGF, E-selectin, L-selectin, and subsequently reduced intimal hyperplasia. It also reduces inflammation by working on the NLRP3 inflammasome cascade, subsequently reducing IL-1 beta, IL-6, which has been proven to be beneficial in the CANTOS trial, resulting in its positive benefit. So in 2020, COLCOT was published. This is colchicine cardiovascular outcomes trial, where patients who is post-myocardial infarction being on a statin therapy was randomized to receive 0.5 milligrams of colchicine per day and followed up to 42 months, as opposed to being given a placebo. And what they found was that it works very, very quickly. You can see on the Kaplan-Meier curve on the bottom right that the curve starts to diverge within the first week and continues to diverge as time goes on, with a significant p-value of 0.07, which is quite staggering. Another trial called LODOCO-2, low-dose colchicine 2, is a multi-center, multi-nation clinical trial. It follows on from LODOCO-1, which looked at using colchicine in patients post-infarct. Again, very similar finding to the COLCOT trial, where you see risk reduction compared to placebo in patients post-myocardial infarction. The downside of treating patients with colchicine, if you give too much of it, patient starts to complain of diarrhea. The upside is that it does act on as an anti-inflammatory and have evidence to reduce cardiovascular outcome. These are some of the trials that uses colchicine, LODOCO, COLIN, LODOCO-2. Colchicine PCR is interesting, where the hypothesis is to give colchicine in patients coming in for percutaneous intervention in the hope that it would reduce recurrent event downstream, down the line. Did it achieve its target? It did not, probably because the follow-up time was a bit too short. However, what's interesting was that in those patients given colchicine, their hsCRP as well as IL-1 beta and IL-6 levels reduced quite markedly as compared to control. So you do have improvement in vascular inflammation health, which potentially could translate to better outcome down the line, should the follow-up be long enough. And when we look at the magnitude of effect from all the studies available from this meta-analysis, again, pretty much driven by Colcott and Lodoco-2, colchicine is beneficial to reduce the risk of developing cardiovascular events. Can colchicine stabilize vulnerable plaques? So here, this is a study where colchicine therapy and plaque stabilization is investigated in patients post-acute coronary syndrome. And similar to what Dr. Simone have shown earlier on, MIP sectional imaging of this artery, in this case, the right coronary artery, using softwares to automate calculation to identify low attenuation plaque, which is pretty much the dark area here, color coding it and calculating its volume. And after treatment with colchicine, re-imaging with CT, coronary angiogram, and quantifying the low attenuation plaque volume, as well as other features of vulnerable plaque. What's interesting is that you see two rows with significant p-values here. That is, in those patients who have improvement in hsCRP, these are patients who are treated with colchicine, and you get reduction in low attenuation plaque volume only in those patients who experience improvement in their hsCRP, not so much in their LDL values. So this gives rise that actually targeting inflammation with colchicine or statins would actually drive down your event rates further on top of your current statin therapy. This is a study worth mentioning, using methotrexate to try and suppress your inflammation cascade. Unfortunately, it did not really work. The third trial, presented in 2018, did not show any significant differences because the level of cytokine activation, IL-1 beta, IL-6, hsCRP, was not augmented. Therefore, cardiovascular events remain the same between the two arms. So coming up to this point here, where I'm actually putting two studies side by side, CANTOS investigating targeted treatment towards inflammation, as well as FOURIER targeting low levels of LDL, both showing significant changes in terms of outcome, which is quite remarkable because CANTOS was the first hsCRP or inflammation-directed therapy to be presented. What is remarkable from the FOURIER trial is that it's actually driven by myocardial infarction, hospitalization for angina, myocardial infarction, as well as coronary revascularization. And the events is seen more so in those patients who experience greater reduction in their hsCRP compared to those who did not shift in their hsCRP levels, either because of taking statin or other exogenous causes that can cause their vasculature to remain inflamed. I shall now move on to another therapy that targets not so much LDL or vascular inflammation with CRP, but to look at triglyceride, which have been sidelined for a while. A lot of our focus since 2019 have been directed towards LDL therapy. Patients who have elevated triglyceride are given statin as a first-line drug and considered to go on fibrates or fish oil as second line, as well as assuming a healthy lifestyle. Hypertriglyceridemia on top of well-controlled LDL consists of 15% or 15 to 25% of the population out there. This data is from a large hospital information system registry from Canada that look at about 2 million patients, isolating those with well-controlled LDL with elevated triglyceride And they found about 25% of their population would still have raised triglyceride. And these patients experience about 13 to 15% risk of events, similar to what is seen in the REDUCE-IT trial. Therapy towards triglyceride have been hit and miss, where there would be some intervention using fibrates showing significant p-value in terms of reducing cardiovascular death and non-fatal myocardial infarction. The JALIS trial from Japan using icosapentael 1.8 grams in patients with high cholesterol, randomizing 18,000 patients, shows improvement in terms of composite endpoint for myocardial infarction, stroke, and sudden death. REDUCE-IT, published recently by Deepak Bhatt, uses icosapentael 4 grams given as 2 grams twice a day, targeting patients who have been on statin, but still have high triglycerides, and it shows significant reduction in terms of the risk of death, MI, angina, and revascularization. So very much a game changer. So what they did was screen 20,000 and randomized about 8,000 patients to either icosapentael 4 grams a day or placebo. And I know there's some issues here with the placebo containing mineral oil, potentially increasing vascular inflammation and magnifying the result of the fish oil that is being studied. Patients must be on statin therapy and have well-controlled LDL levels. And when we look at the result, there is clear improvements across the board, from total mortality, despite crossing the line of unity, to cardiovascular death, angina, non-fatal stroke, myocardial infarction, as well as revascularization. So huge effect. And when we compare it to a high-dose statin versus low-dose statin, improve it, we see that the REDUCE-IT trial gives you a bigger magnitude of effect of about 25% risk reduction for cardiovascular events in patients who are already well controlled. So, in conclusion, for evidence-based medical therapy to stabilize vulnerable plaque and regression of atherosclerotic vascular disease, we have several drugs in our armamentarium. Any statin probably should and can be used, making sure that their LDL is targeted to as low as possible. Those who cannot take statins, or those who are remaining as very high risk patient with uncontrolled LDL levels, should consider adjunctive therapy with PCSK9 inhibitor, which would drive down the LDL levels further, conferring greater risk, and has been shown to result in lower incidence of cardiovascular outcomes. And we must be wary that despite having low level of LDLs in our statinized patient, these patients could still be experiencing event. And the residual risk in the clinical trial population is about 30%. In the real world population, it's probably between 10 to 20%. So HSCRP is not routinely monitored or sampled, but maybe it is a step in that direction, especially for patients who are well controlled, young, active, and you want to get whole of the vascular inflammation better. Inflammation is now useful as a target. I've discussed with you canakinumab targeting IL-1 beta, showing quite profound risk reduction in terms of cardiovascular event, as well as a cheap drug called colchicine, commonly used in gout, and now being administered in clinical trials to patients post-myocardial infarction, where it is shown to reduce revascularization as well as recurrent myocardial infarction. Triglyceride as a target is potentially one way to go. Icosapentael is available in the US at this point in time, given as 2 gram BD with a 25% risk reduction for all cardiac events. With that, I would stop here. And if there's any question, I would gladly take it. Thank you.
Thanks, Sazali. Really enjoyed. Again, another tour de force lecture covering a lot of ground. We have finished 3 lectures focusing on backwards optimized medical therapy, stable coronary artery disease, and acute coronary syndrome. Maybe I'll just direct one question at Sazali or Paul. You showed actually a lot of data on anti-inflammatory therapy, whether from colchicine And CANTOS has been published for a few years. Is anyone aggressively practicing anti-inflammatory therapy for coronary artery disease? Sazali? Is this your usual practice to add colchicine?
From a clinical point of view, not routinely. Not routine in our post-MI patients. Thankfully, a lot of these Malaysian patients would have concurrent gout, so they will be on either allopurinol or colchicine therapy, so indirectly protecting them. But as a routine, it is something that we probably should look into. Reason why not to use it would be the side effect of diarrhea. If we trust the data, 25% risk reduction is quite profound, and it has been reproducible. So I'm sure it'll be in the guidelines in the near future.
Any questions for the other two speakers? Anyone from the panel? If not, I think I'd like to thank the first three speakers and close out session 1 so that we can ask Paul to chair session 2. But brief summary so far, Paul, passing on to you. I think the most evidence-based lecture was the one given to Sazali. And there's still a long ways to go in terms of optimized medical therapy. Before we move on to anti-inflammatory therapy, just like the highlight in Asia Pacific, even guideline-directed optimized lipid diabetic therapy, most patients are still not on target. So we still have to focus a lot of efforts on implementation before we move on to further novel therapy. Thanks a lot for my first three speakers. Paul, I'd like to introduce the next speaker for the lecture. Thank you, Paul.
Sure. Thank you, Jack. Now it's time to move on to the next segment of our webinar. Let me introduce our first speaker for the second half. It gives me pleasure to introduce Dr. Hiromasa Otake, who is from Kobe University Graduate School of Medicine. So he's going to talk about intravascular imaging for peripheral vascular disease. Hiromasa, please.
Thank you, Dr. Carl, and ladies and gentlemen. I'd like to talk a little bit about plaque characterization by vascular imaging in PAD. First of all, unfortunately, there are actually not that many evidence about vulnerable plaque characterization by vascular imaging. So I'd like to proceed with my talk by introducing some of the previous papers for lost patients with histological analysis, as well as non-invasive and invasive imaging modalities. So these are today's my topics. As everybody knows, arteries of systemic circulation can be subdivided into muscular or elastic types according to the relative composition of elastic and muscle tissue in their clinical media. So elastic arteries are usually located very close to the heart because those are the arteries that transport large volume of blood from the heart. In elastic arteries, media contains a high density of elastic fibers that allows the vessel to stretch and spring back. And usually an aorta and its major branches such as carotid artery and subclavian arteries can be categorized as elastic artery by histology. On the other hand, muscular arteries usually located away from the heart, and it distributes blood to the muscles and internal organs. The media of the arteries have a higher percentage of smooth muscles than connective tissue. Coronary artery, internal carotid artery, and peripheral artery like femoral arteries can be histologically categorized as muscular arteries. As I will talk about it later, plaque characteristics can be different according to the location of the artery, and some of these differences can be explained by these histological differences of the arterial wall. So let's look at the atherosclerotic plaque characteristics in peripheral artery disease compared to other arteries. So this is an autopsy study enrolling 100 individuals who died for several reasons. And they did an histological analysis of the plaque in the coronary, carotid, and femoral arteries. In this study, they classified the plaque into several categories according to the modified age classification of atherosclerotic lesions. And category 3 to 5 contains lipidic components so that they defined it vulnerable, whereas the others as stable. So looking at this figure, sections from the coronary arteries and carotid arteries had the highest prevalence of atherosclerotic plaques, with lipid plaques being more frequent than fibrous plaque, the yellow ones. On the other hand, unlike the carotid bifurcation and the coronary artery, the femoral arteries were not very prone to form cell lipid-rich plaque, like this figure. Also in this study, they subdivided the plaque into three different categories according to its location from the heart. In the proximal one, mid one, and distal one, they define them as elastic artery, transit artery, and muscular artery like this. The proximal coronary artery was categorized as transit one. And looking at this figure, in the transit and elastic artery, the lipidic component is relatively large, whereas on the muscular artery, like orangish ones, the incidence of lipidic plaque were quite low, and the fibrotic stable plaque were predominant. So far, all the data were from autopsy of lost patients. So let's take a look at the data of living patients. This is a paper published in 2012 by Matsuo et al., enrolling a total of more than 150 patients who underwent VH-IVUS imaging, and in patients with plaque in coronary, renal, carotid, and iliac artery stenotic lesions. The slice with the smallest lumen cross-sectional area was studied, and they categorized the plaque into the following 4 types, like virtual histology-based TICFA, thick-cap fibroadenoma, PIT, and the fibrocarotid plaque. If you look at left-hand panel, you can clearly see that in coronary and carotid arteries, the percentage of fibroadenoma like thin cap or thick cap fibroadenoma was quite high, whereas in the iliac artery, the percentage of fibroadenoma was very low, and the PIT and the fibrocarotid plaque were predominant. So atherosclerotic plaque phenotypes were heterogeneous among 4 different arteries. Especially iliac arteries had more stable phenotypes compared with coronary artery. On the other hand, if you look at the relation between remodeling and the plaque composition, that relation can be shared by different arteries. So in positively remodeled vessel, the fibroadenoma was predominant in all arteries, whereas in intermediate and negatively remodeled vessel, the PIT and the fibrocarotid plaque were predominant. So though PAD had lower incidence of fibroadenoma, the relation between the type of remodeling and the plaque characteristics were consistent among the vessels. So let's go back to the previous postmortem study to see the relationship between the age and the plaque composition. So the x-axis shows the age decade of the patient, and y-axis shows the plaque type distribution. As the patient gets older, there was an increase in atherosclerosis severity in all arteries like this. However, if you focus on the percentage of, on the younger ages, the plaque was relatively high in coronary artery and carotid artery in patients with aged between 30 to 39, but in femoral artery and internal carotid artery, the incidence of the presence of plaque was quite low. So we can say that atherosclerosis develops slowly in femoral arteries as compared with coronary artery. So this is another example of the atherosclerosis progression in SFA. So looking at the incidence of plaque in coronary artery and carotid arteries, the incidence was quite high in younger ages, but in SFA, the incidence of the plaque was quite low, especially in younger ages. Especially in persons with plaque in SFA, plaque was always present in the coronary arteries. These findings were also confirmed by a recent clinical registry enrolling a total of 67,000 patients with atherosclerosis. So in each registry, 12% of patients had PAD, but more than 60% of such patients also had atherosclerosis in other vascular beds like coronary artery or cerebrovascular diseases. So probably I think I can say that since atherosclerosis develops slowly in peripheral artery, once you find PAD, there is a higher chance of having atherosclerosis in other vessels. So let's move on to the main topics of today's talk, which is about the distribution and characteristics of coronary plaque in peripheral artery disease. So this is a clinical study of patients, 133 patients with PAD who underwent MRI of the proximal SFA. They defined high-risk plaque as the presence of lipid-rich necrotic core and intraplaque hemorrhages by MRI. So let's look at the main result. What they showed was that the presence of lipid-rich necrotic core was 22.4%, and the prevalence of intraplaque hemorrhage was only 0.3%, which was observed only one plaque out of more than 300 plaques. The only risk factor of lipid-rich necrotic core by MRI in PAD was current smoking. So in the discussion section of this manuscript, they introduced some of the result of carotid artery, and they said that the prevalence of lipid-rich necrotic core on MRI was around 40 to 70%, and intraplaque hemorrhage was 28%. So probably from this study, we can say that the lipid-rich necrotic core or coronary plaque was significantly, infrequent in patients with PAD as compared with carotid arteries. So these data were mainly from, non-significant stenotic lesions in peripheral artery disease. And we recently published the data about the patient who underwent EVT for de novo femoral popliteal artery lesions. And in this study, we evaluated the feasibility of OFDI to evaluate or to guide EVT procedure in our center. So 52 patients with PAD who underwent EVT were enrolled, and OFDI was performed before and after EVT. So I'm not quite sure how many of you guys have an experience of OFDI scan for peripheral artery disease. So it's very simple three-step procedures. The first of all, we just insert a sheath to SFA and the complex CFA by hand. and to get a clear visualization. And then flash with low molecular dextra and scan it. So the tip of the imaging was like here and scan it. So we can get this kind of very high quality OFDI image in peripheral artery. So there are various types of findings we can see, like nodular calcification, thrombus, and macrophages, like we can see in the coronary artery. So in this study, we also evaluated the incidence of vulnerable findings by OFDI, such as vasovasorum, macrophage, and thrombus. The incidence of vasovasorum was 34%, macrophage 66%, and thrombus 64%. So these unstable findings was not infrequent, actually, in patients who need EVD in our daily clinical practice. This is the take-home message of this clinical study, I think. So similar assessment was previously done by Dr. Okura et al. By using intravascular ultrasound. And they enrolled a total of 101 patients with iliofemoral plaque and who need a PTA for those lesions. And during the EVT, they did IVUS and evaluated the presence of plaque rupture, and found out that the presence the prevalence was 41.4% in such patients. Also, they found that in each arterial segment, like CIA, EIA, SFA, a clear clustering pattern of the plaque rupture to the proximal thirds was demonstrated. These findings were quite similar to the findings we can see in the coronary artery, especially in LAD, I think. So in this study, they showed that the male and the history of ACS were also clinical correlates of plaque rupture in the iliofemoral arteries. So finally, in this study, they also evaluate the clinical significance of plaque rupture in those peripheral arterial disease. So like shown in the left panel, the incidence of MACE was not statistically different between the patient with versus without plaque rupture. I'm not quite sure if this is because of the low numbers of patients or not, but it's not statistically significant. However, if they did add the peripheral vascular event, such as unplanned vascular intervention and amputation to MACE, the incidence of such clinical event was significantly high in patients with plaque rupture as compared with those without plaque rupture. So probably, although this is a retrospective observational study, but this data may suggest that the presence of plaque rupture may be a risk factor for future clinical event if you consider the vascular event as a adverse clinical event. So in summary and conclusions, ladies and gentlemen, a post-mortem study shows that coronary artery and carotid arteries had the highest prevalence of atherosclerotic plaques, with lipid core plaques being more frequent than fibrous plaques. On the other hand, peripheral arteries were not very prone to lipidic plaque formation. And since PAD progressed slower than atherosclerotic progression in other arteries, even if it is asymptomatic, the presence of PAD could be a strong predictor for future clinical event. The presence of vulnerable plaque in the plaque rupture is not uncommon in patients who underwent EVD, but prognostic implication of such findings warrants a prospect larger sample size clinical study to further confirm previous findings. So thank you very much for the kind of introduction. This is the end of my presentation.
Thank you very much, Dr. Otake, for a wonderful talk. I think intravascular imaging for the peripheral artery disease is something quite new to some of us, and I think this will bring up a very interesting discussion. Do we have any questions or comments for Dr. Otake's talk? Okay, if not, may I ask Dr. Otake, I think the postmortem study, in that study, you have reviewed, and then you gave us a impression that the lipid core is more frequent for the coronary instead of the iliofemoral.
Yeah.
But we know that these are postmortem autopsy cases. So is it possible that patients with coronary lipidic plaque tends to die so that they are collected in this postmortem study, while the peripheral case, I mean, iliofemoral lipid-rich plaque patients, they tend to stay well alive, so that they are not included in this, or they're not represented in this postmortem study or observation.
Yeah, it's a very good question and a nice comment for my presentation. And as I mentioned earlier, the postmortem study enrolled various types of patients who died for various types of reasons. So if we just focus on the patients with cardiovascular death, the incidence of lipidic plaque in peripheral arteries might be much higher than the one we observed in the previous ones. However, usually the PAD progress are slower than coronary artery diseases and initiating later in older ages than coronary plaques, so that it depends on the patient ages, I guess.
Okay, so to respond to the theme of our webinar, do you think that a vulnerable plaque or a lipidic plaque in peripheral artery is actually a risk factor indicator or some target for us to treat?
Oh, thank you very much. I think it's an important risk factor for future clinical event, and but it's not a target for the treatment right now, because positive the incidence of clinical event is still lower in such patients just who have plaque rupture or coronary plaque, and all the data was just a retrospective observational one, so that we definitely need to wait for the prospective study results.
Thank you very much. So if no further questions or comments, we'll move on to the next talk. But thank you, Dr. Otake, for a wonderful presentation. Thank you.
Thank you.
Let me introduce our next speaker, Dr. Lin Maoxin, from the same institution, National Taiwan University of Hospital. He's going to talk plaque characterization in carotid and cerebral vascular disease, another interesting topic. Dr. Lin, please. Maoxin, you are in mute. Can you turn on your microphone?
Cool. Can you see?
Yeah, we can see the slides and we can hear you now.
Okay. Thank you, Professor Gao. Thank you for your introduction. And today I will talking about viral plaque characterization in the carotid and cerebral vascular disease, a risk marker or intervention target. So this is slides show my outline. What I would say that first of all, I would start from the guideline. Is any guideline that talking about something about the viral plaque inside the guideline? And then the concept of the viral plaque come from the coronary artery disease. But so what is there any different from the carotid artery disease? And then in the past decades, I think that a lot of the paper or study have using a different imaging tools to observe the carotid viral plaque. And I would say a lot of the feature of the viral plaque in carotid disease, and then correlate with their outcome and endpoint. And then is these all features of carotid viral plaque could guide our treatment. So the first of all is a guideline, the latest AHA guideline for the prevention of stroke in patients with the stroke and TIA. The latest one was published in the 2014. And you can see that most of the guideline recommendation talk about the treatment for the cardiac atherectomy or cardiac stenting. And you can see that the base, almost we based the recommendation for treatment is based on the first of all is the patient's symptom. Patient with the patient have an ischemic stroke or TIA in the past 6 months, and then combined with the patient's ipsilateral severity of the coronary artery disease. So all we concerned about in the guideline is stroke, TIA, and the percentage of luminal stenosis. So what about the intracranial atherosclerosis recommendation? There's almost no role of the endovascular intervention in the intravascular atherosclerosis. So major treatment should be the pharmacological treatment, but you still can see that the statement inside the recommendation, that's all we, the treatment still based on the stroke and TIA and the severity of the intracranial vessel stenosis. So also, there's no word talking about the viral plaque inside the intracranial atherosclerosis. But there's something different in the ESC guideline talking about the peripheral artery disease that published in the 2018, and there's an algorithm talking about how could we treat the patient with coronary artery disease. Still part of the algorithm showed about the patient's symptom, and we divided the patient's coronary artery stenosis severity to treat. And you can see that with a patient with symptomatic and the patient's coronary stenosis more than 50%, we still can do the not only the medical treatment, but also some intervention or treatment. And the patient had the mild disease, the base should be the medical treat. But there's another statement that put into the algorithm of this version of guideline is that if the patient are asymptomatic and the disease is moderate to severe, there's some words say that the patient, if they have a future of suggesting high high stroke risk on medical treat, they can the interventional and vascular or coronary and atherectomy and the coronary stenting should be considered to treat. So I would discuss later about this part. So what about the definition of viral plaque of coronary disease? I have said that the concept of a viral plaque comes from the coronary artery. So, but the coronary artery really provides us a very good target to observe the viral plaque because the coronary artery is bigger than coronary artery, and a lot of image tool, including ultrasound, CT, and MRI, can provide us very good spatial resolution to the plaque's composition and its progression. So I think that for coronary plaque, all type of plaque with a highly likelihood of a thrombotic complication and rapid progression should also recognized as a viral plaque in the coronary disease. So in the 2018, the Lancet Neurology had published a review article talking about the image feature of a coronary plaque vulnerability. They reviewed several, many studies that used in the past decade that using different image tools, including CT, MRI, and ultrasound, and give us some image feature of a coronary plaque, a vulnerable coronary plaque, including that the first the coronary plaque volume and thickness, and the plaque surface morphology mostly is irregular, ulcerative. There's a gross picture of the plaque. Also inside the plaque, we can see that intraplaque hemorrhage and lipid-rich necrocortical and thin fibrous cap, and then plaque inflammation and neovascularization should also be observed through the current novel tools. The first of all is the cardiac plaque volume. We can using CT, MRI, and the ultrasound to have a very good measurement to the cardiac plaque volume. Even some paper has said that the plaque volume more than 40 millimeter square on digital analysis through the ultrasound should be a risk marker for the further stroke. And so all the paper that using plaque volume management measurement say the same thing. Result is that the large plaque volume will have a higher risk of a stroke and TIA. And then the carotid plaque thickness is the synonym to the plaque volume. Also, we can use all the CT, MRI, ultrasound to see the to measure the plaque thickness. And there is consensus that the plaque as a thickness greater than 1.5 millimeter, we can see that it's a plaque. And all the paper, a lot of paper, especially one quantified by MRI, have said that the maximal plaque thickness are strongly associated with the cerebral ischemic symptom. Is better than the degree of stenosis. And the plaque surface for morphology also serve as a feature of the vulnar plaque, and it could be categorized as smooth, irregular, or ulcerative plaque. And not only the irregular morphology, but also the ulcerative morphology are all considered as a risk of the feature of risk feature of the stroke. And because the ultrasound is easily to have a cause shadow by the classification, so I think the CT and MR will be a better tool to observe this plaque surface morphology. And then when we look inside the intraplaque hemorrhage, intraplaque composition, and from a lot of study that the most powerful image parameter that associated with the stroke is the intraplaque hemorrhage. You can see that these two patients from their MRI, DWI, one have ipsilateral acute stroke infarction, and the other one is no. And you can see that the patient in that have acute stroke, that the plaque, the carotid, ipsilateral carotid, have a high signal intensity ratio inside the plaque, but the other one is less. So also the intraplaque hemorrhage can show in other technique of the MR. So there's a paper in 2013 has analyzed, review the carotid plaque MRI and the stroke risk, and do the meta-analysis for such a previous study. You can see that why we say that's a powerful risk marker, because when we're putting all the data together, you can see that the intraplaque hemorrhage is very powerful to predict a further stroke. And the correlation is not only appeared in the asymptomatic patient, but also in the symptomatic patient. So the best tool for to observe the intraplaque hemorrhage would be the MR. And the CT, the weak point of CT is then difficult to differentiate between the fibrous lipid and the intraplaque hemorrhage. And also ultrasound has low sensitivity and specificity for the intraplaque hemorrhage. So I think the best image will be the MR. The other one will be the feature of the inside the plaque will be the lipid-rich necrotic core, which has also mentioned before by a lot of paper. And we can observe the lipid-rich necrotic core through the ultrasound. There's two features of the lipid-rich plaque. Like one is echolucent plaque, and the other one is increased juxtaluminal plaque area. You can see that there is pictures of our carotid duplex, and this is CCA and it's carotid bulb plaque distributed in this area, and there's a lot of echolucent area inside the plaque. So that will be a lipid-rich area. So if the echolucent area near the surface of plaque, then we can say that it's a juxtaluminal plaque area. Okay, so from the MR can provide us more and more clear feature of the necrotic core, lipid-rich necrotic core. You can see that from T1 MR T1 weight, that the lipid-rich plaque will be isotense signal, and in T2 weight is hypointense. But when we do the gadolinium injection, because gadolinium can go through the tissue with a microvascular lecture. So you can see that the thin fibrous cap can be enhanced very well, and the necrotic core become less enhancement. So we can, through the contrast enhanced T1 weight image, we can clearly see the plaque, lipid-rich plaque area, and also we can see the thin fibrous cap very well. So the same paper also analyzed the previous study, putting together to see what about the lipid-rich necrotic core and thin fibrous cap. Is there a correlation to the stroke risk? You can see both of these features correlate very well for the further stroke and TIA risk. And the best image to detect to this future is our MRI. And because they can, MR can distinguish between the lipid-rich necrotic core and intraplaque hemorrhage very well, but much better than the CT and ultrasound. We also know that the chronic atherosclerosis is a process of inflammation. So detection of the inflammation inside the plaque may be referred to the plaque vulnerability. So still, but we have to say that many image tools that now still investigated how to detect the plaque inflammation and intraplaque neovascularization. The best one now is the PET using FDG or sodium fluoride. But the main disadvantage of this is that high radiation dose. CT and MR have their own limitation, so right now still only for research study. And we can using ultrasound to detect some microbubble in the plaque, and maybe it's can represent of the vasculature and inflammation. But I have said that the ultrasound is operator dependent, so it's also another good tool to see the inflammation and the neovascularization. So 2019 Stroke also published a paper to collect and pool the data, all the study that studying the PET with the cardiac plaque and correlated with the ischemic stroke. And you can see that, when we PET combined with PET and CT, this is a 72-year-old patient with bilateral high-risk carotid artery disease, and we can see that both carotid artery have significant FDG uptake, and the patient also have both bilateral symptom of the ischemia. And the FDG PET also can combine with the MR to see. You can see this one is a patient with although the less than 50% stenosis, but the FDG PET can uptake in the ipsilateral carotid artery. So when we putting all the 11 studies combined with PET and the stroke, and we can see that. But I have to say that all these studies are retrospective, because when the patient had a symptom, have stroke, and we do the PET, FDG PET for them, and then we found that higher FDG PET uptake is uptake in the ipsilateral carotid artery than the asymptomatic artery. So whether the FDG PET can be a provide predictive value for the carotid stroke risk, I think is still a question. So could we using the circulating biomarker to predict carotid vulnerability? And the unfortunately, the answer is no. We not yet have a reliable biomarker to demonstrate enough sensitivity and specificity to our daily practice. So I think it would maybe further to combine the image study together, maybe provide us some more information. So let's back to the our guideline. We have talking about before that the patient with a symptom or minor disease, we already know that have a very good treatment guide. And then with a patient without symptom but have a moderate to severe disease, or what kind of feature can guide us to do the intervention. The PEP guideline also take some information is that when the patient has symptom, the contralateral TIA stroke or explanatory silent infarction, and then some feature of ultrasound like stenosis progression, and what I'm talking about large plaque and echolucent plaque or increased juxta-plaque area, and then MR can also provide some guide to do the intervention that the patient from MR we have seen that intraplaque hemorrhage and lipid-rich necrotic cold. We can guide our patient to do the further treatment. So I conclude that I think there's several features of cardiac plaque such as intraplaque hemorrhage, lipid-rich necrotic cold, or thin ruptured fibrous cold, plaque volume, or some surface morphology different, and neovascular inflammation are promising as a biomarker for plaque vulnerability. And this biomarker can right now also written into the guideline that can help us to management patient and non-learning depend on degree of stenosis. Thank you.
Okay, thank you, Mao Xin, for a brief presentation on the carotid plaque in terms of the vulnerability and the method of detecting those, and probably some treatment guidelines based on that. Do we have any questions or comments for Dr. Lin's presentation? Okay, if not, Mao Xin, I remember maybe 15 to 20 years ago, there's an Italian group who had published several articles regarding the echographic finding of plaque vulnerability. I remember at that time, there's a term called grayscale measurement. That is a more objective measurement for the plaque heterogeneity in terms of echogenicity. You have mentioned that CT, MR, and PET are more or less investigational right now. Echo is more practical, but then it's operator dependent, describing the features of the plaque. So is there any way of artificial intelligence or more objective method to quantify or measure the vulnerability of carotid plaque?
Yeah, you're right, Popogao. It's because the problem of the ultrasound is that it's not easy, like occlusion area and like juxta hypoechoic area. It's very subjective to mention. It's not very easy to quantify the area bigger, and the plaque volume is easy. We can do that from the echo. So I think that you're right that maybe a further study can using the AI to help us to quantify the hypoechoic area inside the plaque, and to do further prospective study to provide us because even the CT MR we still some radiation problem. And the more repeatable or more one will be the ultrasound. I think AI will be the further future to do that. To maybe it can guide us for the treatment in the future.
Okay, thank you. Because of the interest of time, we'll have to move on to the next presentation. Okay, thank you, Dr. Lin, for a nice one. Our next speaker will be Professor Yadav Bhatt from Nepal, who is the senior consultant cardiologist and surgeon from Norvik International Hospital in Kathmandu. His topic will be a more broader perspective, which is the from DAPT to NOAC for the antithrombotic therapy for ASCVD. Professor Bott, please.
Thank you, Dr. Halcon. I will be talking on evidence-based antithrombotic therapy for vulnerable plaques in atherosclerotic cardiovascular disease. From DAPT to NOAC. Now, one of the advantages of being the last presenter is most of the things are discussed, so it becomes relatively easy for you to continue or substantiate on that. I have no disclosures to make. If you look at the non-stenotic plaque destabilization, it causes almost 80% of the deadly myocardial infarction. That means most of the acute atherosclerotic cardiovascular disease that we are looking at occurs from non-stenotic plaques. And this is what is important to recognize, that there are dangerous forms of atherosclerotic plaques which are not very stenotic, but they are prone to thrombus or form thrombosis. And these are the ones which we all know are called the vulnerable plaques. Now, if you look at the culprit plaque in terms of terminology, this is a retrospective terminology, whereas the vulnerable plaques are a prospective terminology, and the vulnerable plaques further became culprit plaques. Now, there are various forms of vulnerable plaque that has been discussed previously. Things become very easy for me now. That most common form of vulnerable plaque is the plaque which has got plenty of macrophages, a lot of necrotic lipid tissue, and a thin fibrous plaque. The other form of vulnerable plaque is the plaque which has got a mild erosion of its cap and infinite degradation, and this causes further thrombotic cascade activation and formation of thrombus. The other form is the one which has got a small mural thrombus, otherwise known as the wounded plaque itself. And other form of thrombotic vulnerable plaque is the plaque which has got a calcium nodule and which is also likely to rupture and produce a subsequent acute coronary event. The critically stenotic, more than 75 luminal narrowing plaques are also a form of vulnerable plaques, but their incidence is relatively low. So if we look at the different types of vulnerable plaques, as we think of treatment of these plaques, we have to consider the treatment of all these forms of plaques in total, so that we can prevent atherosclerotic cardiovascular disease. Now, if you look at the pathophysiology and responsible for acute coronary syndrome, ruptured plaques form around 70% of the ACS, and in this 20% is by stenotic plaques, whereas 50% is from non-stenotic plaques that get ruptured. Now, non-ruptured plaques causing acute coronary syndrome is by the erosion, the calcified nodule, or healed, fissured healed plaques, which form around almost 30% of the total ACS that occurs. Hence, if we're thinking of tackling or treating the vulnerable plaques and preventing acute coronary syndrome, our aim would be to break the chain of atherosclerosis, stop vulnerable plaques from rupturing or fissuring or getting traumatized, and thereby preventing acute coronary syndrome or acute atherosclerotic cardiovascular disease as such. There are a lot of emerging techniques, as we have discussed previously, for the detection and evaluation of vulnerable plaques, starting from invasive techniques, intravascular and non-intravascular invasive techniques, which are almost 13 to 15 of them. Again, there are a lot of non-invasive techniques like MRI, which has been discussed very nicely before the speaker before me, ultrasound techniques, and EBT techniques, and CT techniques have been evaluated, and the nuclear imaging techniques have also been evaluated. There are also techniques of serum markers and endothelial function tests, which have been evaluated or are emerging techniques for the diagnosis of vulnerable plaques. But the problem is none of these techniques have been authenticated. They have not become standardized, and none of them have been come out to be a definite technique for detection of vulnerable plaques. The very fact that there are so many under evaluation techniques for vulnerable plaque has led on to the question of, is there a validity of vulnerable plaques? There have been papers where they say that the results of vulnerable plaque oriented approaches have been poor. It may be in terms of personalized risk assessment or in terms of guided treatment effect. So there have been questions about the validity and usefulness of this vulnerable plaques. And there are theories that there is no such incidence for thing called vulnerable plaques, but it is the normal plaque which rapidly enlarges over time and then becomes a vulnerable plaque. Whatever it may be, what we are concerning now is vulnerable plaque is a very important plaque. Or in other words, the plaque that causes acute coronary syndrome is important. Because many individuals, the first presentation is sudden cardiac death. We need to prevent this, and this is going to be the biggest challenge for the upcoming medical field. And even those patients who survive the first event of acute coronary syndrome, they remain at high risk for second event. The event rate is almost 10% at 1 year and 5% every year for the subsequent years. Now, this is the challenge that we are facing, that we have to stop this subsequent acute coronary events or first acute coronary event, so that we do not lose patients, or we are doing maximum to our patients. Now, this is what happened. This is the first acute coronary event, and subsequently every year, the non-culprit vessel has an incidence of almost 5 to 10% of event rate for almost 5 to 6 years. Now, in the prevention of coronary events, we need to do the primary prevention by identification of vulnerable individuals, may it be by plasma markers, invasive or non-invasive testings, and we need to do the secondary prevention by identification of vulnerable patients and the vulnerable plaques. Now, there have been a lot of work into the treatment of vulnerable plaques. It has been seen that in the animal study, it has been seen that lipid-lowering diets and treatment converts fatty plaques into the fibrotic plaques. The fatty plaques, which are probably the vulnerable plaques with a lot of lipid-laden material, a lot of macrophages and a thin cap, to a more stable fibrotic plaque. In human studies, intensive LDL lowering with statins has shown to prevent events resulting from the vulnerable plaque. In a 2-year follow-up IVF study, it has been shown that marked reduction of LDL was associated with almost 11% coronary plaque volume reduction, and thereby maybe stabilizing the plaque and thereby preventing it from further rupture. There have been a lot of studies in relation to high density lipoprotein. Increase in SDL will increase plasma stability, because SDL accelerates reverse cholesterol transport and lowers the oxidation level. The agents that have been evaluated is the niacin, which increases SDL by almost 30%, and Orcitribab and JTT705, which produced elevation in up to 50% of SDL. However, there has been no clear translated into clinical benefits. There has been no clear translation that this elevation of SDL translates into clinical benefit to the patients. Thereby, these drugs have still been under evaluation and yet not been standardized. Now, there has been a lot of classification of systemic therapy for vulnerable plaques. For example, it has been grouped into 4 types of groups. The group 1 is the therapies with biological possibility and positive clinical evidence, that is statins, AC inhibitors, beta blockers, and aspirin. Group 2 is therapies with biological possibility but negative clinical evidence, that is antioxidants, folic acid, and antibiotics, which have not been proved to have any benefit to the patient. Group 3 are therapies with biological possibility but conflicting or conclusive clinical evidence, that is angiotensin receptor blockers, omega-3 fatty acids, antihypertensive agents, and so on. And there's group 4, which is therapies with biological possibility but not clinical data available, like peroxidase proliferate activator receptor antagonists, cholesterol esterase transport protein inhibitors. So there have been only theories that have been postulated for therapy for vulnerable plaque, but they are yet to come into a biological as well as clinical evidence of a treatment stabilizing the vulnerable plaque. What about stenting for vulnerable plaques? In a rabbit model stenting, they showed that lipid pore size has been reduced by stenting, forming an additional fibrous cap on top of the stents. In the different trial, where 325 patients were taken, it's a human trial, angioplasty or stenting versus medical therapy for intermediate stenosis, like with FFR of more than 0.75. In a 15-year follow-up, they found no difference whether you manage it medically or whether you put in a stent in the patient. Again, in a case, in the primary study, preventive angioplasty in myocardial infarction trial, 465 patients with myocardial infarction post-infarct RT-PCI were divided into two arms. The non-culprit vessels. Vessels with more than 50% lesions, they divided into stenting versus no stenting or medical management. In the 6 months and yearly follow-up with a mean of 23 months, they found that sealing of non-obstructive vulnerable plaques prevented coronary events in these cases. So, results of direct plaque intervention by stenting has been conflicted. There has been no conclusive positive results in this field either. Now, let's look at targeting platelet aggregation and coagulation. As we know, platelet aggregation and coagulation are highly interdependent processes. Platelet aggregation occurs followed by coagulation. Now, what happens if we do a combination of ASA, the aspirin, and the P2Y2 inhibitors? This has been clearly shown in various studies for different drugs like cure for clopidogrel, Triton TIMI-38 for prasugrel, and the Plato trial for ticagrelor, that the combination of two antithrombotics which act at different sites has reduced ischemic events with very little rise in major bleeds. However, despite dual antiplatelet therapy, what has been found that the recurrent cardiovascular events and death still is up to 10% in these patients who are on this treatment. So what do we go in for anticoagulation? Hence, the studies on the role of anticoagulants in patients with acute myocardial infarction or acute cardiovascular disease. Now, aspirin plus warfarin was compared to aspirin alone after coronary syndromes. This was a meta-analysis of almost 25,000 patients, and it showed that aspirin plus warfarin at an INR of 2 to 3 double the risk of major bleeds, but it was superior to aspirin alone in preventing major adverse effects. The point to be noted is the doubling of the major bleeds, which is a very dangerous thing for the patient as such. So it was seen that this is not a very safe method to do so. Now, there have been a lot of trials and there have been a lot of results for NOACs with dual antiplatelet therapy. There are trials for rivaroxaban, the Atlas ACS 2 TIMI-51 trial for apexaban, APRAISE trial, Redeem trial for dabigatran, and other trials, which show that ischemic events by combining a NOACs to dual antiplatelet therapy reduces the ischemic event, but the event of bleeding event is significantly high as compared to only dual antiplatelet therapy in these patients. Again, what about NOACs for CVD and PVD? This again is a meta-analysis. They enrolled 10 randomized controlled trials comparing NOACs versus control treatment like placebo, single platelet or dual antiplatelet therapy in almost 66,500 patients. And they found that NOACs decrease the risk of mortality. However, they increase risk for major bleeds, which is quite significant in these patients. Hence, and again, they compared, is there any difference between warfarin and NOACs? The study of 7 RCTs, a meta-analysis in patients with atrial fibrillation and coronary disease, they found that there was similar all-cause mortality and cardiovascular death, stroke and MI and major bleeds with NOACs and warfarin. The conclusion was that NOACs at least is as effective and safe as warfarin in atrial fibrillation and coronary disease where or peripheral vascular disease. With all this, it is to be concluded that antithrombotic therapy should be given to all patients with coronary heart disease. If acute coronary syndrome, then we think of dual antiplatelet therapy. NOACs and anticoagulants will be needed only to those patients who direly require these drugs because they have an additional problem. So the 2020 ACC expert consensus has the following to say. It says that anticoagulant will be needed for patients with acute coronary syndrome or coronary syndrome who have associated atrial fibrillation or venous thromboembolism. They may have any other need for anticoagulations like prosthetic valve. And use of triple therapy is to be given for a month. And if a patient has an atrial fibrillation, NOACs is preferred over VKA. So, in terms of optimal secondary prevention after acute coronary syndrome, risk of vulnerable plaques events remains up to and beyond 12 months. Dual antitherapy should be confined to selected patient population. We still lack ideal treatment for vulnerable plaque and have to work hard and do more investigations or more research in this field so that.
Okay. Yeah, thank you very much, Professor Bhatta. That was a nice sum up or summary for the pharmacology for vulnerable plaque. But basically, I think for the treatment of vulnerable plaque itself per se, or to stabilization of vulnerable plaque, there is no firm recommendation from any of the society's guidelines, correct? We cannot hear you. Professor Bhatta, can you hear us? Yeah.
Yes, I can hear you.
Okay, great. So is it fair to say that for all the society guidelines so far, there is no specific recommendation for antithrombotic for the treatment of particularly the vulnerable plaque per se?
Yeah, yes, you're right.
Okay, so do we have any comments or questions for Professor Bhatta? Okay, Professor Bhatta, as a cardiologist and a surgeon, what is your actual concern for the antithrombotic treatment for patients with ACVD? The bleeding or anything else?
The concern of treatment with antithrombotic therapy is actually the bleeding itself, because the patients are already on 2 antiplatelets, and then we add one more anticoagulant to them. And normally we do it to only those patients who are at high risk of thrombosis, like a patient has a prosthetic valve or he has atrial fibrillation. Otherwise, in just acute coronary syndrome, we rarely add an anticoagulant.
Good. And also in your process of reviewing this topic, do you have any opinion on the use of 2B3A inhibitor, especially in patients presented with acute coronary syndrome? And in that background, obviously, a vulnerable plaque is involved.
We have had experiences with using 2B3A inhibitors in patients who've got a lot of thrombus burden. We've been doing that for the past many years now. But because the in vulnerable plaque, I have no recall of using or having read a paper which says 2B3A inhibitors are useful for vulnerable plaque. But patients who've got a lot of clot inside the arteries. Actually, I'm not a surgeon. I'm an interventionist. Somehow I am also labeled as a surgeon. Maybe it's an honor for me, but I don't know how to use the knife. So
Okay.
if the patient has a lot of thrombus, we do give them 2B3A inhibitors, and they have shown to be quite useful to our patients.
Yes. Okay.
What is the experience in your sector?
Yeah, I think in our clinical practice, 2B3A is still reserved for those presenting with acute coronary syndrome, and we only use those very selectively and also in a very short term because of the obvious bleeding risk. Yeah.
Yes.
Okay. So I think the second half or second segment of the webinar is also very interesting because we have heard 3 wonderful talks, one specifically on the peripheral artery disease, basically the lower limb artery, the other one by Dr. Lin regarding the carotid plaque and the cerebral vascular disease, and the third one by Professor Bhatt regarding the antithrombotic treatment for patients with vulnerable plaque. I think it's suffice to say that we still have a lot of investigation or research to do because at least there is no society guidelines for these specific topics. It means that we have a lot of unknown facts, and also we need to do more research into establishing the treatment guideline for these vulnerable plaques in arteries elsewhere from coronary artery. Okay. Do we have any further to add? If not, I think it's my privilege to host this webinar, and I think we will close the session. I thank you all for the wonderful talks of our speakers, and also I'm grateful for your attendance for this webinar.
Thank you.
Thank you.
Thank you,
everyone, and take care. Hopefully we can see you in person very soon.
Thank you.
Okay.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye bye.
Bye-bye.